I don't know what it is with that computer, but something to do with that. So I was here and I was showing you fracts, and you get these numbers like this. And then when you look at TBS, you get something like this, and it gives you an idea of this trabecular bone strength. And if you can see two people with the same bone density, but one has a much lower trabecular bone square, it means there's much more heterogeneity in the bone. And that means the trabecular strength is worse. And so what you do is click on this adjust with TBS, and then you enter the manufacturer and the TBS, and it will recalculate fracts. And so this is a way to adjust the bone, or adjust the fracture risk for bone quality. So that's one of the things we're doing that's more recent. Another thing that's become more evident in recent years is recency of fracture. And this is data recently published. It's from Iceland. And what they found was that if you had a vertebral fracture within 2 years, for example, you had to multiply the MOF, major osteoporotic fracture risk, by a number to get the real risk. So the younger you were, the higher this multiplier was. So for example, if you take a 50-year-old woman who has a new vertebral fracture and then calculate her fracts, you need to multiply the major osteoporotic fracture risk by about 2.5 to get a true estimate of the fracture risk. Now, I don't know if this is going to be true in other populations. This is a study from Iceland, but I think most of us who see a lot of osteoporosis patients know that fractures cluster, especially vertebral fractures. And it's important for us to intervene quickly because this is a situation where people can have multiple fractures in a short time. The other thing to remember is that, we do look for fractures, and the more severe they are, the greater the risk for subsequent fractures. I don't even try to call grade 1 fractures unless there's a clear change from a prior image, but grade 2 and grade 3 are what I will try to call on imaging. And one of the ways we can do that is with vertebral fracture assessment on our bone density equipment. So I will typically order my bone density if the place where the patient's going has VFA software with a VFA. And this is the image you get. This is a normal one. And see this one, this patient has a grade 2 vertebral fracture here. And the question is when this should be done. When should we look at either a VFA or a side view of the spine? And there's a whole long list from the NOF of when this should be done. But the bottom line is if it's going to change a diagnostic classification, and if it's going to change whether you treat a patient. Is it going to change a patient from no treatment to treatment? Or is it going to change a patient from treatment with, say, a bisphosphonate to treatment with anabolic therapy? So I do this a lot. Now, another thing that's become very recently recognized is the use of opportunistic CT to get some idea of these things. So this is a patient who, this is what I do when I see this patient's had a chest CT, but if they've had a abdominal CT, I do the same thing. And I can get with the sagittal reconstruction a very nice view of the spine. And as you can see, there's a compression deformity here. And the other thing you can do is put these next to each other and get, typically we use L1, but you can use another vertebral body close to that if needed, like a lower thoracic body, or if L1's compressed or something, you can use L2. And you can, put your cursor over and put a little elliptical area and look at the Hounsfield units. And roughly, if it's less than 100, that's osteoporosis. 100 to 150 is low bone density. And if they've already had high IV contrast, I subtract 10. This is crude, but it gives us additional information that's already there in the chart that you can then assess without doing additional imaging. So just to remind people, osteoporosis can be caused by medicines. I'm not going to go through this list. Obviously, steroids is the biggest thing. But don't forget androgen deprivation therapy in men with prostate cancer and aromatase inhibitors in women with breast cancer. And we also need to recognize that there's a whole bunch of underlying disorders that can cause osteoporosis. And we need to keep that in our mind when we when we see a patient with osteoporosis. So the best data, about 1/3 of postmenopausal women with osteoporosis have a secondary or contributing cause. And so if you have a patient with osteoporosis, or you're going to treat, or have fragility fractures, or bone density is going down on treatment, you need to evaluate them. And this is what I would consider the standard basic evaluation. Obviously, history and physical, a routine chemistry panel, you have to add the phosphorus. There's no way to know which patient's got a hypophosphatemic disorder, although rare, they're there. And, I see one a year. And so you have to add this. It's no longer on the chemistry panel. A CBC, a TSH, I will typically do a 24-hour urine for calcium and creatinine. Low urine calcium in a patient with normal renal function and not on a thiazide could suggest malabsorption, and high urine calcium might suggest idiopathic hypercalciuria, and that we might treat with a thiazide. A vitamin D, a PTH, testosterone in men. If you have a young man with bad osteoporosis as a diagnostic thing, to want to make sure you're not missing it. If it's an older man in whom I wouldn't treat with testosterone, I may not check it. And then there's the second kind of panel of things we do. And that's, SPEP and UPEP or something like that. A Cushing screen, malabsorptive evaluation. This I have a low threshold for screening for celiac disease. If they have GI symptoms, a family history of celiac disease, a high risk, so they're type 1 diabetic, for example, they have a 4 to 8% of risk of celiac disease, unexplained secondary hyperparathyroidism, unexplained low urine calcium, and high vitamin D requirement. And then these other things we do less frequently. So let's not forget, when we're thinking about the patient, don't smoke cigarettes, don't drink too much alcohol. In the patient who's got vertebral fractures, physical therapy and fall prevention is important. Falls are bad. In some patients, vertebral augmentation for painful vertebral fractures. I don't want to go through this controversy, but obviously there is a lot of controversy about this. Calcium, vitamin D, and drugs. And just to review calcium, you want about 1,200 milligrams total daily. Don't forget the diet, supplement to goal. And vitamin D, what should the level be? Well, just to throw a little controversy in, we all say it must be more than 30, but if you look at the best data, fracture risk goes up at about 20, below 20. So the Europeans think we're nuts in going for 30. The Institute of Medicine said 20 is enough, but I think many of us go for 30. And so enough vitamin D is clearly important. There is some data that very high doses can have adverse effects on bone strength, particularly in women. The non-classical benefits, cancer, heart disease, and so forth, are unproven. I can tell you I use 30 to 60 as my goal range. The other important thing that's been recognized in the past couple of years is that the standard assays that we use don't recognize 25-hydroxy D2 very well. So if you're using ergocalciferol 50,000 units, you might be underestimating the level by as much as 40%. So if you're going to use D2, you need to measure by HPLC tandem mass spec, which is in most of our systems a send out. And I can tell you that this study that Neil Binkley published on this used specimens from our system and our platforms, several of the platforms in Milwaukee. So dose regimens, 1,000 a day, will typically raise it 5 to 10. And I am using almost 100% daily D3 now, because I want to be able to measure what I'm giving. So who should get drugs? typically we say people who have osteoporosis by densitometry, people with fragility fractures. And if they're in that osteopenic range, in the United States, we use either a hip fracture risk of more than 3% or major fracture risk of more than 20% over the next 10 years by FRAX. So what are the drugs? I'm going to skip calcitonin because it probably doesn't do hardly anything. I won't talk about raloxifene and estrogen, although they are drugs which decrease bone loss and prevent fractures. I'll talk about the bisphosphonates, which decrease bone resorption, denosumab or Prolia, which decreases bone resorption, teriparatide and abaloparatide, which increase bone formation, and then the newest drug, romosozumab, which both increases bone formation and decreases bone resorption. So remember that bisphosphonates increase bone density, they decrease bone turnover, they cause osteoclast apoptosis, and they prevent bone loss in early postmenopausal women with steroid therapy. They've all been shown to decrease vertebral fractures, and some have been shown to decrease non-vertebral and hip fractures. Well, what are the problems? Well, with the oral, you can get esophagitis. With the IV, this acute phase reaction, you can't use it in a hypocalcemic patient, and you can't use it if the kidney function is not adequate. And then these rare things, the musculoskeletal pain, I'm not so sure about that. ONJ is real, but rare. In the osteoporosis doses, somewhere between 1 in 1,000 and 1 in 10,000. And then the atypical femur fractures, I want to mention that because that is real and it's something patients worry about. So these fractures occur from here to here. And they typically occur, they look like this. They have this medial spike. They start off with a little bump on the lateral side, and they typically occur without trauma. And they're real, but I think it's important to remember that if the patient is significant risk for fractures, these are much less than the fractures prevented. So this is a study just recently published, and I want to focus on this red box. This is the first 5 years. And in the first 5 years, because the rest of it's kind of theoretical, I quite didn't understand how they did it. But in the first 5 years, the top line is the number of clinical fractures prevented. The blue line is the number of hip fractures prevented. And this bottom line is the number of atypical fractures caused. And as you can see, this is Asian, white, and Hispanic women. The fractures prevented are far higher in all groups. I will make the point that in Asian women, these lines are a lot closer. And Asian women are at much higher risk of atypical fractures than other groups. So one of the questions about bisphosphonates is how long should we treat? Well, when it's stopped, the drug effect persists. Bone turnover slowly increases and bone density decreases. Fractures slowly go up. The risk of atypical fractures decreases. Now, the American Society for Bone and Mineral Research says you can treat up to 6 years with IV and up to 10 years oral. I'm more conservative. I typically treat with 3 to 4 years of IV or 5 to 7 years of oral and follow them. But how long? So I can tell you, it's not based on good evidence, but I monitor bone density and a marker of bone resorption. I use the fasting cetalopeptide. And if either that goes up above about the midpoint of the premenopausal range or the bone density starts to go down, that's when I retreat. And obviously, if it's a very high-risk patient, I may go right to anabolic therapy. Now, one thing that's come up in recent years is, do bisphosphonates reduce mortality? And this is obviously an interesting question because it could be another benefit. Observational studies with the oral suggest they do. I'm a little skeptical because we've been burned a few times. But this is a randomized trial. This is where people got 1 dose of zoledronic acid, IV, after a hip fracture. And as you can see, there was about a 25% risk in mortality, about a third of which was attributed to fracture reduction. The other 2/3, not really clear, but not fracture reduction. And there's a more recent study where they treated women with osteopenia, with 4 doses of zoledronic acid IV over 6 years. And I'm not going to go through each of these hazard and rate ratios, but the bottom line was there appeared to be a decrease in the risk of death and perhaps cardiovascular endpoints. So why might they reduce mortality? Fractures, they inhibit the same pathway that statins do. They may decrease cardiac hypertrophy and vascular calcification, and perhaps decreased bone resorption may decrease inflammatory cytokines coming out of bone. So my kind of conclusion about this is they might, but they might not. I think the randomized trial data with zoledronic acid are very suggestive. The rest is observational, and we've had a lot of observational crap over our careers that didn't work. And there's one meta-analysis that showed no decrease in mortality. I wonder if the IV isn't different than the oral, but it's just a question that's out there and interesting. Now, I want to move on to denosumab or Prolia. The rank ligand system is something that regulates osteoclasts, and activation of this system increases osteoclastic differentiation. And denosumab is a monoclonal antibody to rank ligand. And this drug increases bone density and decreases fractures very nicely. It's given by shot, sub-Q, every 6 months. There may be a question of skin infections. Again, ONJ and atypical fractures are the same. Again, you can't use it in hypocalcemia. You can use it in more significant chronic kidney disease, but you have to remember when patients have chronic kidney disease, you need to think about what their underlying bone disease is. Very complicated system. But the offset is very different than bisphosphonates. They have a long tail effect. The effect is very quickly reversible. So what happens when you stop it? Well, this slide shows bone density, and it doesn't matter whether you look at 2 years of treatment, 8 years of treatment, or 10 years of treatment. The bone density in 1 year, as you can see in all these slides, goes down very quickly when you stop it. I mean, if you look at this, in 10 years, you lose more, you stop it for 1 year and you lose more than everything you've gained over that 10-year period. Very quick bone loss is bad. And this is probably why. This is that marker of bone resorption. And this is the placebo group. And you can see they're not getting anything. Their bone resorption marker stays the same. The denosumab group is treated for 2 years, and their marker of bone resorption goes down very, very dramatically and fast. And then when you stop it, it goes up above baseline and appears to stay above baseline for months. So there's a rebound increase in bone resorption. Well, what happens is that markers go up, bone density goes down fast, and there's reports of clusters of spine fractures. And I've now seen several of these myself. There are even reports of hypercalcemia after stopping denosumab because of increased bone resorption, mostly, but not all, in children. And it appears that the longer someone was on denosumab, the greater the bone loss when it stopped. So why might this be? Well, on the right part of the slide is bisphosphonates. They impair osteoclast function mostly by causing osteoclast apoptosis. And remember, it also stays in bone, so that effect slowly goes away. Denosumab does those, but its primary effect is to impair osteoclast differentiation. So what happens when you're on denosumab for several years is a bunch of baby osteoclasts accumulate. And all of a sudden you take the brakes off and they race through maturation and start tearing down bone. So after this was first reported a few years ago, Dr. McClung wrote this article, Cancel the Holiday, and said, you can just keep them on it. So this shows that bone density goes up to 10 years. I have to admit, I have some angst about treating a patient indefinitely with a very potent anti-resorptive drug, which essentially comes very close to really decreasing bone remodeling to a very low level. How about changing them to an anabolic agent? Well, this is from something called the data switch study. And the red line is when you switch them to a anabolic agent. So at least initially, bone density goes down and bone markers go way up. So that's not something you're going to do. How about changing them to a bisphosphonate limited course? So I'm going to summarize lots of papers in this one slide. There are two papers in which denosumab was given for 2 doses, 1 year, and alendronate was effective in preventing bone loss in both those studies. That said, there are case reports of multiple fractures after stopping denosumab and using oral bisphosphonates. And these patients presumably got longer courses of denosumab. And oral bisphosphonates may not be adequate after long denosumab treatment. With IV zoledronic acid, there's mixed data. Some people think if you wait till 8 months rather than 6 months after the last DMAB, it's better because you've allowed the remodeling space to open up and you can get the denosumab in. But there are several studies, and basically it prevents bone loss in some but not all patients. And many of the patients needed a second dose, often about 6 months after the first dose, to keep you from having excess bone resorption. So that's probably what we're going to do. It's the best choice, but in my opinion, you need to monitor bone resorption and a bone density. When you start someone on denosumab, you need to tell them, 1, they can't skip doses. 2, we need to have an exit strategy, or we're going to continue this the rest of your life. They're 90 years old, they're going to stay on it. But if they're 60, you need to figure out what that exit strategy is up front. So I want to focus on just the left side of this screen. So this is European guidelines just published in January. And they say if it's up to 2.5 years, you can use oral bisphosphonates or zoledronic acid, but monitor bone turnover markers and BMD. If it's more than that, and you want to take them off, switch to zoledronic acid, give a dose at 6 months, measure that bone turnover marker at 3 and 6 months, and consider repeat infusion of zoledronic acid. So this is something where you really have to do active monitoring. I want to move on to the anabolic agents. The first one is teriparatide, or Forteo, and this just shows the dramatic reduction in fractures that we get with this anabolic agent. This is abaloparatide, or Tymlos. Bone density change is the same. Excellent vertebral fracture and other fracture reduction. With these drugs, it's typically limited to 2 years. Rodents get bone cancer, so we're not supposed to use it in patients with Paget's disease or radiation therapy that might increase their risk. There is now 15 years of use with teriparatide data and no evidence of increased osteosarcomas. And the black box warning was just removed for PTH 1 to 34 a couple months ago. You can't use it with pre-existing hypercalcemia, and I'd be careful if they're hypercalciuric and have kidney stones, because urinary calcium does go up. It needs to be followed by anti-resorptive therapy. If you don't follow it, you will lose all the benefit. It may be blunted by prior bisphosphonates, but we still do that. We don't use it after DMAB, as I showed you earlier. There is some data that you can get greater bone density increases if you combine anabolic therapy with zoledronic acid or denosumab at the same time. But this is expensive and there isn't data on fracture reduction. One thing that I think people need to know, efficacy probably requires weight bearing. It doesn't work very well in wheelchair-bound patients. And I think that's kind of important as we talk about the next agent. The next agent is romosozumab. So basically, this system, this Wnt system, is inhibited by something called sclerostin made by osteocytes. And sclerostin, when you inhibit this pathway, you get decreased bone formation and increased bone resorption. Now, it's known from nature that there are mutations of sclerostin, von Buchem disease, and sclerostosis, where you don't have this inhibitor and you have a high bone density disease. So if you can block it, you get increased bone formation and decreased bone resorption. And that's what romosozumab is. It's an antibody to sclerostin. And in this study, this is called the FRAME study, there's dramatic bone density increases with romosozumab. Interestingly, the bone formation marker goes up, but doesn't stay up very long. It's really the first 6 months or so that it goes up. And bone resorption marker goes down. Now, in this big study, only vertebral fractures were reduced. And it's complicated, but it's probably because they got too many patients from Latin America who had a lower fracture risk. And so non-vertebral fractures were significantly reduced if you excluded the Latin American patients. It is what it is. The next study is called the ARCH study. And this is an active comparator study. So these patients got 1 year of romosozumab followed by a year of alendronate or 24 months of alendronate. And the drug reduced vertebral fractures by 50%, clinical fractures by 27%, non-vertebral fractures by 19%. Here was the concern. There was heart attack and stroke, 2.5% in the romosozumab group and 1.9% in the alendronate group. And that actually slowed approval and raised concern. So it's now approved that does cause ONJ and atypical fractures. You treat with a monthly injection for 12 months, and you have to follow it by anti-resorber like a bisphosphonate or denosumab, or you will lose the benefit. It can be used if you've had prior radiation, and it's probably a better anabolic in a non-weight-bearing patient. So the cardiovascular issue, this is a big deal for us. It was again seen in the ARCH trial. Some people have speculated, well, maybe the bisphosphonate is beneficial, and that was the difference. It was not seen in that other trial, the FRAME trial. There was one study done on men where there was a signal for that, but the numbers are tiny. It's a much smaller study, but eight events in the romosozumab group versus 2 in the placebo. I don't know if it's real. They're doing a post-marketing study. It is not recommended now if they've had a cardiovascular event within the past 12 months or while on treatment. And I, for now, am avoiding this in any patient at high risk for cardiovascular events, and I certainly tell them about it. So which drug when? We use the oral bisphosphonates as kind of our standard treatment in many patients, although I have gotten, so I prefer IV zoledronic acid in patients kind of with the typical osteoporosis. Whoops. And I prefer this because I'm sure of compliance. I don't have to worry about absorption. I don't have to worry about the, 50% of patients weren't taking it at a year, and it has a long tail effect. I use denosumab much less because of the issues associated with it, but in patients who won't or can't take a bisphosphonate. I use the anabolic agents, all of these in patients that are really high risk for fractures. If I'm going to use a PTH analog, I actually pre-auth both of them and see whichever is cheaper for the patient. If the patient has a very high fracture risk, the best sequence is anabolic first, followed by anti-resorptive. So in patients who already have, say, vertebral fractures, I would typically start with an anabolic agent, followed by anti-resorptive. So this is to summarize, consider the fracture risk, not just the T-score, evaluate for secondary causes. I like my vitamin D levels to be 30 to 60 and a total calcium intake about 1200. Address the fall risk. Pharmacologic therapy in appropriate patients. Certainly the benefits far outweigh the risks when the fracture risk is high. With bisphosphonates, I use holidays, and I base it on the drug and duration, markers, bone density, and the risk. But there's not really good evidence on how to do this. You don't give a holiday for DMAB. You can't just stop it. It's not safe. All the anabolic agents need to be followed with anti-resorptives. Now, what's most important is we need to get patients with fragility fracture managed. Fractures cluster. A fracture should be considered a sentinel event, and we need system fixes for this. In our place, we have fracture liaison nurses that are part of orthopedics, and they actually do a terrific job in capturing more of the patients. We also need to convince high-risk patients that the risk of not taking a medication is far greater than the risk of taking a medication. And what I tell them is, yeah, that you have a hip fracture, there's an increased risk of death. But more importantly, there's a really significant risk that you'll end up in a nursing home. And patients seem to care more about that. So let's go back to this diabetic patient who has a hip fracture, complicated hospitalization. So what we would do is I would do a bone density. I would do some kind of spine imaging to see if she has compression fractures. If TBS were available on the machine, we would do it. There's no charge for it. Evaluate for secondary causes. In her case, her TSH was suppressed. But she tells me, well, but I feel better on higher doses. And this is where you have to tell patients just because something makes you feel good doesn't mean it's good for you. Suppressed TSHs are associated not only with bone loss, but atrial fibrillation. I feel better with chocolate. I have patients occasionally who feel better with cocaine, but it doesn't mean it's good for you. I would change her from the pioglitazone. The TZDs both decrease bone formation and increase bone resorption and are associated with an increased fracture risk above that already associated with diabetes. Not sure of the significance of the PPI, but I think they're overused. We would do physical therapy for fall prevention, and we would no doubt treat her with some pharmacologic agent. I want to do one more slide to quickly mention what else is new. And hypophosphatasia, which is deficiency of tissue nonspecific alkaline phosphatase, is a disease with the broadest range of severity of any inherited bone disease, from essentially asymptomatic adults with low alk phos to life-threatening infantile forms. And we now have enzyme replacement therapy that's approved for childhood onset disease. This is life-saving in infants, life-changing in children. I think it also helps some of the adult patients with clear childhood onset disease. I have a couple of those on treatment. And not so sure about the people who are diagnosed in adulthood with minimal symptoms. The next thing, FGF23 mediated hypophosphatemic rickets. So this is like X-linked hypophosphatemic rickets or tumor-induced osteomalacia in adults. And for X-linked hypophosphatemic rickets, there's an antibody to FGF23. It works very well. And for those patients with tumor-induced osteomalacia in whom you cannot find the tiny mesenchymal tumor that's causing it, this drug also works very well. And the last area where I'll mention new stuff is hypoparathyroidism. In those difficult to control patients, PTH 1 to 84 was approved a few years ago. And in those patients, it can really make a difference. Unfortunately, there was a production problem and it's been unavailable for a year and a half or so. This is an injection which is given daily, but to be quite honest, works better twice daily. And maybe even 3 times daily, and in some patients by an insulin pump. But this is really exciting. This drug is in phase 3 trials. It's a form of PTH for patients with bad hypoparathyroidism that has a 60-hour half-life that can be given in a daily dose. And the studies that have been done so far look very, very promising. So with that, I'll stop. I apologize for the technical problems. I'm not sure why that computer's acting funny, and I hope I didn't go too long, but I will happy to answer questions.
I applaud your poise and persistence to work through those technical difficulties and deliver us a great lecture. I hope I was curable. I didn't have any. And we certainly are ready to open the floor to questions for Dr. Shaker.
Joe, I got a question. The Prolia and Remosumab are both monoclonal antibodies. Now, when you stop Prolia, you get abrupt decrease in the bone density and fractures. Do you have any idea with Romosumab, when you stop it, the same thing happens?
So you will lose the gains you have, but you don't have that, extremely rapid accelerated bone resorption that you get with denosumab. And really with denosumab, I think the thing is that you have this, this buildup of baby osteoclasts, first graders that are just ripped through. And then when they graduate high school, they just start tearing bone apart. And it makes it a difficult drug. Now, many people, way smarter than me, way more nationally known, think denosumab is the premier anti-resorptive agent because bone density increases are greater than bisphosphonates. But if you compare the clinical trials of, there's no head-to-head trials, but if you declare the ZA trial, the 3-year Z, and the DMAB trials, fracture reductions are similar, even though bone density increases may be greater with DMAB. Romosozumab, you lose it. You do need to chase it with something, but you'll lose everything you gain in a way similar that you do with, say, estrogen or raloxifene. When you stop them, you lose everything within a couple of years, but you don't get this just tearing down a bone. Think about all the patients that stopped estrogen after the HERS and Women's Health Initiative trials. We didn't have tons of people walking into the clinic with multiple vertebral fractures. I've seen people with 6 vertebral fractures. So I'm not saying it's not a good drug. It just has to be used so that we make sure we know what we're doing and that we educate the patients well. And I think this has probably happened to a number of patients during this pandemic. We were giving denosumab in the driveway at North Hills. They would pull up and the nurse would go down and give them the injection.
Okay.
Wow. Well, that was a fantastic summary that just makes me even more confident, if that's even possible, to let you handle my patients with severe osteoporosis. But as a family physician, I do use SSRIs a lot. And I was wondering if how cautious I should be in causing osteoporosis or osteopenia, or if there's a holiday, what should I do above and beyond what I normally do to prevent osteoporosis?
I wouldn't. I would do what you normally do. And if people need SSRIs, I think, this association with fractures with some of these drugs is hard to prove if it's causal. With some of these drugs, depression causes bone loss. And I certainly don't think you want patients that are, depressed and anxious or anxious all the time. So I think using the drugs is appropriate. I wouldn't change what I did. I would manage them like any other people. And the same with PPIs. I just have this thing that PPIs are used more than they're needed. And I know they're associated with pneumonia and C. difficile in the hospital. So, but yeah, no, I wouldn't change. I think those patients need those drugs, and I don't think we should withhold them.
Thank you.
Thank you.
Joe,
The incidence.
I'm sorry, if somebody else have a question, let them go ahead. All right. In my post-retirement from active practice career, I'm doing some work with some value-based care programs. And one of the measures that we have in those programs is the OMW, osteoporosis HEDIS measure, where the measure is to, as you know, get the bone density test within 6 months of a fracture, unless the patient had one within the previous 2 years or are they on active treatment already for osteoporosis. So I was just curious about your opinion of that measure, which after listening to your lecture, it did strike me as inadequate before, but it now strikes me as woefully inadequate. And I'm curious whether you agree with that or whether you have had it. Were you to be asked, would you have any suggestions for the HEDIS folks as to what
Well-
might be a better measure?
Well, I think we need to do that. I think we need to get people treated, but I think it's a systems fix. We now, the orthopedics hired 2 nurse practitioners, and they worked with me for a long time, and one does the inpatients, one does the outpatients, and they've gotten up to about 50% treatment, which is, as I said, don't let perfect be the enemy of good. That's dramatic improvement because the nationwide data is about, so I really think it's systems. I think we're not going to do this with just us. A patient has a hip fracture, comes back to their primary care doc, and they've got heart failure, diabetes, hypertension, and they're giving them 10, 15 minutes to see the patient. It's just not enough time to manage all that stuff. So, we need to figure out a way to get those people identified, get their workup done, start on treatment, and then back. And what they're doing is they go over the tough cases with me. They just, I probably talk to them on the phone once a week. And, some of the really complex patients they send to me. But it's a great way to get more patients taken care of. And I just don't think
So
we're set up
you're
to do
saying
that.
that the orthopedic group is taking the responsibility for that. Is that what I'm
Our
hearing you say?
orthopedic division did it.
Yeah.
Now, I don't know where the money's coming from, or I don't have that, or if they generate their salary or how it works, but I can tell you it's capturing way more of our fracture patients, getting them on treatment and then getting them back. I just think, I don't know.
Our experience has been that the PCPs generally hear about these fractures after the 6-month window
Yeah.
for that measure. And so, and we haven't seen a lot of orthopedic specialists or the podiatrists willing to step up and take ownership of doing that follow through because they obviously know the patient had a fracture.
So it's interesting because initially, after they spent time with me, trained with me, and then they went back and they have an hour to see a new patient like me. Some of the orthopods didn't quite understand that, well, because they see a patient every 10 minutes. It's, well, this isn't the same. This requires getting a bunch of information from the patient and teaching them some stuff and stuff. This isn't a 10-minute, visit. You need a hip replacement. That's get you into the pre-op group and then schedule you. So yeah, I think it's extremely important that we do better. And I think the other thing that's happened, hip fractures were going down, and then of course everyone got afraid of the bisphosphonates, and that probably caused fractures to go up and again.
Yes.
But no, I think it's
Joe,
the work that you're doing.
maybe you had it on your first few slides, which I went by too quickly, but do we know whether the incidence of osteoporosis has gone up or down over the course of, long periods of time? Bone is something you can examine even in long buried cadavers, so we could learn a little bit about how bad it was hundreds of years ago.
Yeah. I know there are anthropologic and archaeologic studies like that, but I just don't know the answer. But I do have to ask, where are you sitting?
Oh, no, that's
You'd love to explain that.
that's a virtual background. That's
okay.
That's one of my photographs. In a couple of us go out every month to shoot to take pictures of the full moon, and that's the full moon rising over the Hone Bridge.
Oh,
I become a
great
photographer. Thank you.
It's beautiful. Anyway, yeah, I don't know the answer, but it's an interesting question. There are all kinds of archaeologic studies on different bone diseases and, finding Pagets and rickets that, in ancient
Well, prevention is better than treatment. And, you know, how early can we diagnose this disease? Should we be treating it or at least trying to prevent it much earlier in life?
Well, so some people say it's a pediatric disease manifesting in adulthood. So I think the things we should do are kids need to have adequate calcium intake and exercise
Well,
and
you know,
not drink and smoke.
what's interesting about the calcium intake is most of my grandchildren drink things other than cow's milk.
Right.
I haven't found out whether most of them are supplemented with calcium. I would hope they are.
They are. They are. In fact, almond milk typically has a little more in it. I mean, it's supplemented, like you say. It's not, it's essentially a calcium supplement in a food. It's not natural, but the almond milk typically has about 400 milligrams per 8 ounces. And most of the soys are about 300. But that's interesting. They don't drink any cow's milk.
Yeah, it's truly amazing to me how many people either feel they're intolerant of dairy products or are actually intolerant of something quite remarkable in let's say it's a socioeconomic strata that I which, you know, probably isn't, you know, the inner city or working class people.
Yeah. 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 I think you're right about that.
Hi, Leslie Martin. You had said something about looking at incidental CTs and evaluating them. Now, is that something that you are doing or that you can request would radiology give you pushback because the CT was not taken to optimize evaluation of bone?
So I don't think that I do it myself. And I've gotten pretty facile at it. So I can pull up and put the sagittal in one box and the cross-sectional in the other and scroll and stuff. And so I do it myself. I've never asked the radiologist, but I'm guessing they wouldn't want to put it in a report.
Right.
And because the Hounsfield, I mean, it's, you know, this is stuff that's in the literature, and it's like, it helps me for a couple of reasons. First of all, the sagittal helps me a lot because somebody's had a CT scan of the chest, abdomen, and pelvis, and I see that they have no compression fractures, and they had a CT 6 months ago. I'm not doing a spine X-ray. They don't have to get it. That image is great. I can see that they haven't had one. The Hounsfield units is a little more mushy. But, you know, for example, in steroid patients, they fracture at a higher bone density than typical osteoporosis. And it's probably because they have more microarchitectural deterioration. And it's not rare for their Hounsfield units on the lumbar spine to be much lower, out of proportion to their bone density, similar to the trabecular bone score being very, very degraded.
We've got a couple of hands up if Dr. Angove has a question.
Oh, yeah. 3 years ago, I was giving a talk in Madison, and during the night, I got up to go to the bathroom, and when I was heading for the bed, I slipped and fell and slid across the floor and banged my head against the wastebasket. And I cut my ear. So when I was giving a talk, after the talk, one of the doctors come up and said, Dr. Angove, did you just have surgery on your ear? And I said, no. He says, well, it's still bleeding. What did you do? So anyway, I told him about what happened. And then I had an I didn't have pain until probably the next 1 or 2 days. Then I went to Elmbrook Hospital and had x-rays that showed a fracture, compression fracture of T5, T12, and L1.
Wow.
So I've lost 1.5 inches of height, but during the recovery, I mostly just did posture, keeping my posture good, taking diet to help supplement the calcium and D3 and so forth. And now I don't have any signs or symptoms of a fracture. I'm doing normally. The only sign, of course, is my loss of height. But I'm just wondering, do you see many patients that recover like that?
Well, yeah, you can recover from old fractures like that. But the question from my perspective is, what's your future fracture risk? And I think it's pretty high.
Oh, okay. I'll be careful.
So we would probably work you up and treat you, because, you know, if you fall again, and also fall prevention. I mean, you know, people will often tell me, I fell, but it was an accident. I'm sure everyone's heard this. Well, of course it was an accident.
Sure.
You're 80 years old and you fell. I mean, nobody throws themselves on the ground after about the age of 16. So, you know, I think fall prevention is important, and we would also consider you somebody we worked up and consider pharmacologic treatment, because I don't want anyone to break a hip and end up in a nursing home.
Right. Yeah. Thank you.
Yeah. Thank you for your comments.
I have a question. I may have missed it during your presentation, but all your various meds, do they work equally on cancellous and trabecular, or one over the other?
That's a very, very good question. So the trabecular cancellous bone is the most metabolically active, and their effects are mostly on trabecular, but they also on cortical bone. And in fact, they have to be to have 50% reductions in fractures, because cortical bone is so important for strength. So many of them, where they've done kind of fancy imaging, something called high resolution peripheral QCT, will decrease cortical porosity and have effects on the cortex too. But what's amazing is, for the bisphosphonates, for example, the fracture reduction is far greater than predicted by the change in bone density. And it's probably that they do something to improve microarchitecture or prevent perforations of trabeculae that, you know, result in loss of any functional effect in terms of strength. But I would say ultimately more on trabecular, but some on cortical, and clearly on bone strength.
I said that I was taught that there's cortical bone and trabecular bone. The cortical bone is the shell, and the trabecular bone is the infrastructure that keeps the shell up. And you have to make sure you got trabecular bone.
You need them both, right? Yeah, absolutely.
Are there any other hands up? For some reason, I can't see that.
I see a hand up, Jonathan's iPad, yep.
Yeah, hi, Jonathan Burkhoff, OBGYN.
Yeah,
So, hi. So my question, getting back to the earlier screening, earlier detection, are we waiting too long to make the diagnosis? And then sort of in tandem with that is estrogen, and you sort of touched on it. So as a gynecologist, I tend to screen, I think, a little earlier. When women are menopausal, I start having the conversation about getting a bone density test. I think the internists and family docs and those in the room might speak to this, tend to do it later. But I feel like it's important to establish a baseline and to have that conversation when women are menopausal, if in fact they're not on hormone therapy. And the current recommendations, as at least as I follow them, are if women are not symptomatic menopausally, then we don't use estrogen simply as a bone drug. But my sense is that there's more gravitational force towards estrogen taking on a greater role in management of osteoporosis or prevention of osteoporosis. So I'm just curious about your thoughts on when you think we should be screening, how often we should be screening in the women who are newly menopausal, 50s, and then whether your historic take on estrogen has changed and whether you think that it'll eventually become independently indicated even in the absence of vasomotor symptoms.
So loaded questions. The first one, so the recommendations by the NOF are to wait till 65 unless the woman has other risk factors, but they're pretty broad. If they're thin, smoker, family history of osteoporosis, or have had an adult fracture, should do them at menopause. So I think in that population for sure, controversy between the two, and I'm not sure. I think you know way more about estrogen than I do, but my opinion is that the Women's Health Initiative really kind of screwed us up, and that the timing hypothesis, or whatever you want to call it, that maybe taking estrogen in your 50s is a good idea, and maybe not starting it at 70, maybe starting at 70 is a bad idea. So I think we're coming back around. And so I think you're right. Estrogen clearly prevents fractures. You know, the Women's Health Initiative showed that. And correct me if I'm wrong, I think there's a lot of information that suggests early in postmenopause, estrogen may have beneficial cardiovascular effects. Or am I being too optimistic?
Yeah, no, that is, I think, correct.
So yeah, I think it's coming around more, but I think the Women's Health Initiative, which the mean age was what, 65 or something, really kind of scared us all. And I think the number of people went off it was huge. I use in early menopausal women with, say, a family history of breast cancer and mildly reduced bone density, I will often use raloxifene for several years, and then worry about something, a bigger gun later, you know, to prevent, to decrease their risk of breast cancer and protect the skeleton at the same time.
Yeah. Thank you.
Joe, what is your approach in treatment or non-treatment for the postmenopausal woman with osteopenia?
Okay, so hi, Sandy.
How are you?
Nice to see you.
Nice talk.
Thank you. So I generally will frax them, and I rely pretty significantly on their fracture risk, and we'll use that to determine whether I treat them. And if it's very high, I might go anabolic. If it's just medium high, probably anti-resorptive with a bisphosphonate. But that's kind of what I do.
Sure. Yeah. Sounds good.
Do you have a recommendation of what's the dose of D3 that you prefer?
So for most of us who aren't going to get a level done, I take 2,000 units a day. I don't know what my level is, but it ought to be enough. It'll probably get me between 30 and 60, and I don't worry about it. In patients with bone disease, I measure it and try to get it between 30 and 60. And usually 1,000 will raise it around 5 to 10. So that's kind of what I do. But I use daily D3 almost completely.
I use the 2,000 units also.
Yeah. Yeah. I think it's enough in most of us.
We're coming up on to 8:30 here, so I typically this is when we kind of wind up our Q&A period. Maybe Joe, would you be receptive to an email if somebody has a burning question?
Of course. So I'm gonna give you my my personal email. It works better than my work email. It's joseph.shaker@gmail.com. And feel free to fire off a question. And again, I apologize. I don't know why that, it was obviously something with that computer blocking it, and I'm just really sorry about that. I don't know what happened.
Well, you know, things happen, and you pulled the fat out of the fire very nicely, and we're all very
Thank you for saying
appreciative.
that. And thank you all for attending. It's wonderful to see people I haven't seen in a long time, even if it's just a little square picture.
Sure is. All right, everyone. Good night.
Thank you
And
very much.
hopefully we'll see you all next month. Bye.
Bye-bye.
Good night.